I'd like to welcome everyone to the Adelaide Biomed City Research Mini Reviews. And this week we're going to be talking about SAHMRI on clinical registries. And we're going to talk about two of the clinical registries that we have within SAHMRI. And but before I start, importantly, I'd like to acknowledge that we're on Kaurna land. Although one of our speakers is not on Kaurna land, he happens to be in San Diego. But I would recognise that the majority of the people on this webinar are on Kaurna land, and would like to acknowledge elders past and present and any Aboriginal or Torres Strait Islanders on the webinar today. We have a really exciting mini review this week with two outstanding speakers. We're really privileged to have Professor Steve Graves, who is the director of the AOA Joint Registry. And Steve is currently in San Diego, so we'll be talking in San Diego. It's 11 o'clock there. And then following Steve, we'll have Associate Professor Maria Inacio, who runs ROSA, and we'll be talking about the success of ROSA. I just want to encourage people to put questions in the Q&A so that after Steve's talk, we'll be able to ask some questions. And then after Maria's talk, we'll have some further questions. Steve, thank you very much for staying up so late to do this, and really looking forward to your talk. So I'll let you start now. Thank you.
Okay, thanks very much, Steve. And it's an absolute pleasure to be here. And what I'm going to try and do is explain a little bit around the Australian Orthopaedic Association National Joint Replacement Registry, give you a bit of a concept of what I think that clinical quality registries are, and also give you some understanding of the breadth of what they can do. So the way that I look at clinical quality registries are that they are a continuous quality assurance program, national or large regional, which is actually very much integrated into healthcare systems. They are appropriately designed and governed and managed to ensure that they bring about significant improvement in our health outcomes. The information provided by quality registries aims to increase the use of identified best practice and reduce outcome variation through avoidance of less satisfactory approaches to care, improving outcomes and reducing costs and increasing the value of healthcare. The Australian Commission for Safety and Quality did a report on registries, and they assessed us, and this was back in 2014, and our expenditure to run the registry during that time was around 13 million, but they estimated, and it was their independent estimation, that we had saved over $600 million in healthcare costs up to that time. Things have actually improved significantly since that time, and I'll just go through and explain a little bit why. So the AOA, like all clinical quality registries, are a national learning healthcare system, and what that means is that it's an organisation that collects high quality data which is information rich. And what it does is provides that in real time to the various stakeholders, and in particular clinicians and patients and government, industry and so on, where the information can be actioned. And this results in transformation and interactions within the healthcare system, and a change from being reactive to proactive by identifying both benefits and harms. And what it does is promotes the use of those things that are beneficial and reduces the impact of those things that are less beneficial. But then what it does is it monitors change in the outcomes and care delivery as a consequence of the information that it's provided. And so what it can do is see the impact of what information is provided, and then with the associated improvements, then report those, and then continue the whole cycle. So what you get is a continuous quality improvement. And that's how they work. The Australian Orthopaedic Association National Joint Registry is fully owned by the Australian Orthopaedic Association, but it is undertaken, as Steve mentioned, in partnership with SAHMRI and also the University of South Australia, and that has been a very successful partnership. CQRs can be really quite large, and what we we are one of the largest and actually one of the oldest. We started back in 1999. We currently collect information from all hospitals undertaking joint replacement, which is 319, both public and private, and we have 100% participation. We have 100% participation of surgeons undertaking joint replacement, which is around 1,400. We have over 1.5 million patients recorded on the registry, and they have the option of opting out, and only 47 over the last 20 years have opted out. We have data on over 99% of all procedures since mid-2002, and that's validated against government data to ensure its accuracy and completeness. Currently, we have information on over 1.7 billion procedures, and as you can see, we're approaching the billion mark for knees and 750,000 for hips, and almost 70,000 for shoulders. And there are additional procedures that we collect: elbow, wrist, ankle, spine, and disc. So joint replacement is regarded as one of the most cost-effective procedures, and yearly now what is happening in Australia is around 120,000 are being undertaken. And last year, these are the numbers for hip, knee, and shoulder replacement. One of the things that was actually very important with respect to the registry was to be able to monitor the impact of COVID. And what we found in 2020, there were 7,000. That was the first time the numbers have declined, 7,000 fewer hip, knee, and shoulders. And that is compared to 2009. But in fact, the normal anticipated increase would mean that there was probably around 11,000 procedures less than what we would have anticipated. Now, do they work? And the answer is yes. This is, if we look at the outcome of knee replacement, this is the change that has occurred over time. And you can see that the revision rates have actually declined considerably when those three periods are compared. If we look overall, since we first started in since we first collected full national data in 2002, the revision burden associated with joint replacement has declined of hip replacement has declined from 14.8 to 8%, which, when you put it in patient terms, it means that we're doing about 2,200 less revisions in 2020 than we would have if that hadn't changed. Revision knee procedures have decreased by around 3.4%, and that means there are around 2,050 less revisions in 2020 than there would have been. So you can see it's actually a big impact on the healthcare system. So one of the things, there is a large international network of arthroplasty registries, about 50 of us, that all work together. And I think it is fair to say that almost all improvements in the outcome of hip and knee replacement in the last 10 or 15 years has been driven by data from registries. And I think ours has probably contributed significantly to that. One of the important things with CQRs is that they report, and this is our reporting system, which is we produce an annual report, which is very extensive and is available online, and it has additional supplementary reports associated with that. We provide real-time web access to surgeons, orthopaedic industry, government and regulators so that they can assess individual outcomes from the surgeon perspective, but aggregate outcomes with respect to the orthopaedic industry, government and regulators. We provide detailed individual surgeon reports on their performance each year. We provide ad hoc reports to those interested in undertaking research or needing reports for government policy changes, and that's around 300 per year. We have an automated system for reporting to the orthopaedic industry, and approximately 1,500 of those reports are generated each year. We've got over 200 publications within refereed journals, and we're currently publishing about once every 10 days at the moment. And we normally, pre-COVID, were presenting nationally and internationally around 80 to 100 times per year. We also provide significant amount of consult and advice to stakeholders to improve practice and implement policy change. A major focus of ours has been in healthcare reduction in recent years, and that's around optimising techniques and joint prosthesis to ensure success, policy and process change so that new technology is introduced safely and effectively, identify and determine if drivers for the increasing use of joint replacement are modifiable, identifying and assessing benefit and cost additive interventions to address cost creep, and procedures being undertaken for appropriate indications and the required threshold of symptom severity. And also if cost per procedures can be reduced through process change. So the initial focus of the registry was to collect a highly accurate core minimum data set, and the outcomes were pretty limited to just revision and death. This core data set, however, does remain the backbone of the registry, and the core data set has been expanded over time, including other data points being collected as listed there. We've also added data to our data sets through linkage, and I'll talk a little bit more about that in a minute. We've commenced undertaking registry nested trials. And another thing that I want to quickly touch on is the use of our data within system processes that exist within the healthcare system. So this is the sort of thing that's really quite simple for us to do. It's looking at all prosthesis use and comparing public and private hospital, and you can see that private hospitals have a higher revision rate. But this is really around prosthesis selection, because if we look at the 10 best prosthesis, you notice that the revision rates for both public and private hospital are less than when you look at all prosthesis, but the outcomes are actually the same. So prosthesis selection is a critically important issue in the outcome of joint replacement. Things that we have identified that some of you may well know is the metal-on-metal hips that were a big problem 10 or so years ago, were identified by this registry. And over 150 individual devices that have not performed well have also been identified. We've identified techs and prosthesis types that are most suitable in specific patient populations. We've been able to look at the impact of surgeon experience, surgeon volume and learning curve on the outcomes of joint replacement. And importantly, individual surgeon variation and the reasons for this, and individual hospital variation and the reasons for this. One of the programs that we introduced 4 or 5 years ago was data linkage. And what we do is we link our data set to MBS, PBS, and more recently state hospital admission and ED data attendance. You know, the data linkage is really a very complex and difficult thing to set up, but it better assesses the impact of comorbidities and increased capacity. Linked data is also provides a de-identified case level comparison, comprehensive medical record, and so that is very valuable to us. We intend to add PROMs to that, and the data will be used also to further assess clinical trials. The National PROMs program is currently being rolled out, and we collect information pre and 6 months post-op. In the last 12 months, we've brought on 160 hospitals nationally, and the remainder, up to the 319, will be completed by mid-2022. We're able to collect 90% pre-op and 79% post-op, and these figures are actually very high for national PROMs collections. And patients have access to comparative data, and surgeons have access to individual patient data. So it is helpful with individual patient clinical management. Hospitals and state governments have access to aggregate data so they can look at system change. Just before I finish, I want to mention that we commenced registry nested trials 3 years ago. They are either clinician initiated or industry trials. They use the electronic infrastructure developed and expanded that we use for PROMs. And we also have the ability to collect radiology and investigative results. These are really very cheap and effective platform for assessing the safety for new innovation. And currently we are running 7 industry and 3 clinician-led trials, including the largest randomized trial in arthroplasty globally, which was a 12,000 patient randomized trial. And the recruitment for that was completed in 18 months. So finally, I just want to mention things that are occurring around system process monitoring. We're currently negotiating with the federal government about establishing a system to monitor the safe introduction of short-stay joint replacement. It is close to day surgery, and the safe introduction of that has to be monitored very carefully. The other thing that we're doing is we're having a discussion with state government on the potential to implement a program to prioritise waiting lists and rehabilitation for patients having joint replacement. So you can see that we are very integrated into the normal healthcare systems. So the critical role of CQRs is that they maintain real-time data quality, transparent and accountable. They're probably the only mechanism to assess complex system interactions, and they have the capacity to collect data and enhance capacity for additional evidence collection through PROMs, clinical trials, data linkage, and process monitoring. They collaborate extensively nationally and internationally, and most of our publications are with collaborators. Considered approaches to making data sets available to other researchers is an important focus of ours at the moment. And we undertake extensive international comparisons so that the performance in Australia can be assessed elsewhere. They're very cheap and they're very effective, and they provide quality reporting. Sorry I've had to rush through so much, but it was really just to give you a flavour of about what clinical quality registries can do and what they're involved in. Thanks very much.
Thanks very much, Steve. Great presentation. We are a little bit short on time, but I would like to ask you a slightly controversial question. And that is, do you think that the registry should be making data available to the public in regard to the performance of individual hospitals, firstly, and secondly, individual surgeons?
Yeah, the hospitals is an easier issue because there is precedent for doing that in a number of countries, and there was initial resistance, but people have been very accepting of that, and hospitals have been very accepting of that. The difficulty in Australia with information on individual hospitals and surgeons in Australia is that I don't think that we're quite there, because one of the things that we rely on is the cooperation of hospitals and surgeons to get our data. And if there was any thought that there would be a public release of that data, at this point in time, I'm not sure we would get full cooperation, so the accuracy of our data would be impeded. I do, however, think that it will get there. But it is baby steps towards that process, and I think that that is underway, but we're not quite there yet.
All right, thanks, Steve, and thanks for a fabulous presentation, and the $600 million savings and the immediate ability to look at the impact of COVID. I mean, I think those things are just very clearly show the usefulness of having a registry like this. If you could stop sharing your slides, then we'll move on to Maria Inacio, who's going to tell us about ROSA and using big data to inform improvements in aged care. Thanks, Maria.
Wonderful. Thank you so much for the invitation as well. So I'll start today by just introducing the Registry of Senior Australians, which is a registry that we set up very much in the framework of an Australian clinical quality registry to purposely monitor and evaluate the health, the service utilization, the medication use and mortality, and other specific outcomes that affect older people once they've entered the aged care sector. It was established in 2017 as a bit of a background, and today is supported by 9 different partners. That includes the academic institutions in the state, as well as clinicians, aged care providers, and consumer advocacy organizations. So what the registry does is essentially integrates information from the aged care and the healthcare sector with the aim of improving the quality of aging through the research that we do and the reporting that we do to improve a variety of different aspects of what's happening with these individuals at this point in their lives. There is a team of 16 of us that are sitting here at SAHMRI, and we cover a variety of technical expertise, but we also, as Steve Graves mentioned before, importantly partner with clinical content area experts and a variety of collaborators for most of the research projects that we undertake. So if you have to have a picture of what ROSA is, this is probably the best, I guess, visualization of it. And essentially it shows you that what we have is 2 different cohorts as part of the registry. We set up prospectively enrolled cohort in South Australia. And that means that every South Australian who has an ACAT, which is an aged care eligibility assessment, gives us their permission to obtain the information that's collected at the time of their assessment and integrate that information with a variety of other sources that exist both nationally and within the state. And then we monitor that person until essentially their death. But what we also did while we were setting up the prospective arm of the registry, we set up a historical cohort of the registry that we update every couple of years. We're doing a massive update right now, which includes all of the individuals that have ever accessed any aged care service in Australia since 1997. And it links their information within the sector and then across the aged care sector. And in the next year or so, it also will integrate information from Centrelink, which is social benefits that they receive throughout their lives, as well as the Australian Immunization Registry. So once that information is integrated by a variety of data integrating authorities all over the country, but mostly coordinated through the Australian Institute of Health and Welfare, that information is put up on a space that we work in, where we essentially derive new information from these data, from this linked data, and create a variety of different reports for different audiences, as well as research projects for a variety of interests. So to date, I think ROSA has been very successful. I mean, there's an enormous wealth of information that's available within ROSA, and it has been very successful in publishing a lot of what I would consider probably basic research, telling us what is happening with these individuals, what type of information, what type of services they've been accessing, what are the major outcomes that have been affecting them, because there was very little in that respect at the population level before ROSA was available. We've also were very involved in the Royal Commission into aged care quality and safety, which I'll talk about in a little bit, and also in a variety of outward facing kind of activities where we really tried to do the best we can to spend a lot of time thinking about how to communicate and share the information with the public, essentially. So when ROSA started in 2017, it was a couple of years before the Royal Commission into Aged Care Quality and Safety was announced. And we essentially got caught up on the storm, I would say, of what the Royal Commission became. And we provided information, data, people, knowledge to a variety of the different aspects of their investigation, because at that point, we were essentially the one resource that existed with this information integrated. So during their investigation, we led for the reports that were the in-depth research reports that they conducted around quality and safety monitoring, were involved in the production of an additional 4 reports. We also were provided expert testimonies at different areas at different points during the investigations. And then we even had one of our staff, who's our data manager, who's probably the person that knows the data better than anybody, was seconded to them to help with the data management on their own investigations in-house. We like to think that we contributed to the recommendations that were final, that were made earlier this year. So in February of 2011, the commissioners delivered their report. There were quite a few recommendations that I think were directly influenced by the work that we were able to do for them. And if you want to read and find out more about it, we did write a piece for the Australian Quarterly in July that summarized essentially what the recommendations were, what the government's response and aged care reform plan looks like, and where we think these things really got it right and where they might have fell short. So I encourage you to take a look at that article if you like. So the other important work that we do is that we're able to do a lot of really, I think, cool research projects using this immense data source. And there's a few areas that so far we have developed quite well. So one of the things that we have spent quite a bit of time thinking about is quality and safety monitoring. So identifying the health events that closely affect the individuals in care, that we need to have a system in place that that looks at variation in practice, looks at effectiveness of care, but a standard set of measures that we can use again and again. So we've developed what we call the outcome monitoring system for ROSA, and that includes 12 of these measures. And now we're building work on top of that creates tools that we can use to identify people that are most at risk of having these specific events. And this work that we've done around quality and safety monitoring, risk profiling, is the majority of the work that was used by the Royal Commission. The other bit that was heavily used by the Royal Commission for reasons that probably a lot of the viewers understand is the work that we've done around quality and safety and the quality use of medicines in these settings. So the majority, for example, of the Royal Commission submissions and complaints were around medication use. So it's a problem that's significantly affects a lot of the people that are in our registry. So we have a pharmacist and a couple of pharmacoepidemiologists that work with us that have conducted a lot of work around the quality use of medicines by these individuals, so particularly the medications that have a massive impact on their health, and then some of the services that they access that might help them potentially manage their medication better. We've also done a lot of work around dementia. So as you might imagine, this affects a large proportion of the people that we're studying. So we've spent a lot of time developing ways of looking at the care that is provided to the individuals with dementia in our registry. And we've also done the latest bit of work that we are doing now is around integration of primary care and potentially secondary care services to the individuals that are in residential care or receiving home care packages in the community. And this bit of work has just recently started, but it is a really important new area for us because we know that primary care is the ones that have the most contact with these individuals on almost on a weekly basis, and potentially ones that are really well placed to make a difference in the health and well-being of these individuals. That's pretty much it as far as highlights for ROSA. And yeah.
All right. Well, thanks, Maria. That was fabulous. And clearly ROSA has achieved so much and had so much impact. Very, very impressive. I guess my question to you, sort of 2 questions. Out of all of the stuff that you've presented, what piece of work do you personally like the best? And secondly, what piece of work do you think's had the greatest impact?
Almost like picking my favorite child. That's not a fair question, but look, I'm an epidemiologist, so of course I think the most interesting questions here are the things that the work that we've done around understanding who these people are, because there is a lot of people throw around a lot of numbers and throw around their experience, and a lot of times that doesn't add up to the true experiences that people are having. And we were able to put numbers to a lot of these things. So I think the work that we've done around the epidemiological understanding of this cohort is definitely my personally favorite. However, I do think that the work that has this biggest impact has been around quality and safety monitoring. Our definition and our derivation of measures that are standardized, used nationally to monitor quality and safety of care have already been used significantly by the department, by the commission. Now it's influencing the new expansion of the quality indicator program nationally. And I think it will continue to do so as we move forward. So I think that that is probably the most significant bit of work that ROSA has done thus far.
Thanks for that. And in terms, I guess, having watched ROSA through this period of amazing growth, I mean, the psychotropic work certainly got a lot of media. Do you think that was the one that the public was most interested in?
Yeah, so the antipsychotic use is one of the measures of quality safety indicator. And I think that absolutely was one of the earliest bits of the work that we've done that got picked up. So early on, when we started showing that we had the capability of looking at medication use and quality use of medicines in these individuals at this level, immediately the Royal Commission came to us and said, can you look at the reliance and the antipsychotics use in individuals in care? Can you look whether it changes once they enter care? Can you look at, does it change once they entered and spend some time there? And we've done a bit of work around that, and that was published on MJA last year, and it was chosen as one of the best papers of the MJA last year, so which is we're really proud of. That was work that was done by Stephanie Harrison, which was one of our first postdocs actually in ROSA. So yeah, that's definitely work that we're really proud of, and work that we're going to continue to do a lot of is around this quality use of medicines, psychotropic, sedative medication used in this population.
All right, well, thanks, Maria. And I think we'll wrap it up now. So thank you very much, Maria and Steve, for tremendous talks. I think highlighting the real strength of the registries at SAHMRI. We didn't have Anne's data on today, the kidney transplant and dialysis registry for Australia and New Zealand, but they also do amazing work. So the three together really are three of the biggest and best registries in Australia, and SAHMRI is extraordinarily proud of them. So thank you, Maria and Steve, for terrific talks, really insightful, and I encourage everyone to come back next week for next week's webinar. Thank you very much.